successes. For me, getting people on board with this was kind of like boiling a frog. You start with the water tepid and then kind of slowly turn up the heat over the years. And one of our keys to success really, I think, has been getting resident belief in the decision rule, and them kind of managing up, as it were, to present to the attendings, hey, I want to do a head CT because Canadian CT is positive. And I will say that I think early on, some of our staff that probably had been around longer and were more senior were a little more reluctant. They were kind of like, yeah, but just get the CT anyway, because in my experience, XYZ. I think over the past few years, though, that culture has dissolved. And I think that, the more champions I've gotten among my staff who really demand that the resident justify a CT really makes that part of the conversation, even when those champions aren't there. So, to break it down into phases, I think education and repetition among the residents and the staff was step one. Step two was really explaining to people that, winning flies with honey again this is not, it's a guideline. It is an evidence-based guideline. And we understand you're not going to follow it 100% of the time because, you have your own reason for doing a CT. Maybe the dangerous mechanism isn't listed and you thought it was dangerous. I understand that. But what we're trying to get you to do is the right thing more frequently. And I think that really helped at least establish the groundwork. I think two breakthroughs that we had that I would share is that, I think there is a bit of this is another documentation hoop, and so what, and why don't I just click a box when I order an Epic? I did the Canadian CT rule and it was positive. Why isn't that just an automatic click box? And I've countered that with, we think that this is medical decision making that would be beneficial and better for your defense if something were to happen, that you actually use the rule and this is why, instead of just clicking a box. The second thing is we had to make it easy for people, and that we have a dot phrase, had a dot phrase, and now have basically a clinical decision tool grid that's built right into people's medical decision making, that allows them to access it. And admittedly, people aren't using it 100% of the time, but they're using it 20 or 30% of the time, which is actually pretty good. And those ones we can really solidly claim as in accordance. The last part then, I think, gets to well, so what? We're doing a better job of documenting. What about all the CTs I didn't do? I'm not getting any credit for those. And that's a big pushback I've gotten from people. And, I kind of give them the belief in the fact that we really value all that work as a group. And we've been able to demonstrate, and if any site has not done this yet, I would really strongly encourage you to go back and look at when you started Medic, of the patients who met the criteria as a minor head injury from that big pool, and then the percentage of those people that received a CT scan compared to where you are now. When we looked at that, it was really jaw-dropping. And I don't know, I don't think all other sites had as big of a drop, but I was able to go to my staff and say, listen, great job increasing your documentation. That is awesome. Keep it up. It's good practice. It's a good way to teach your residents the right way to do things. But let's look at how many people we were CTing in the same group of patients from then to now, and we cut that CT rate almost in half. And I think that was a moment for people to say, wow, like this actually is generating something that we think is positive for patients and positive for patient care. And although I wasn't able to give people individualized CT rates pre and post, I do think that the goodwill and positive message that's rippled through the group has been a good one. I'll pause there if anybody has a question. And then I was going to kind of update where we are now with things as far as turning up the heat a little bit. Okay, well, I don't see any questions just yet. I will just say, I guess, we did education, education, education. We gave providers customized, basically, report cards or scorecards every 6 months. We've been doing that for probably 4 years now, where we basically show a bar graph histogram and let them see where they are, where the medic target is, and where the group average is. And then they can kind of see they're below the target and the average, and that they're an outlier. That's been motivating. And then just recently, in the last 6 months, we have actually started taking all of our CTs that were deemed inappropriate and directly messaging them through our quality assurance process and peer review. And so we get 100% replies for all of our QA inquiries, because our providers know that all those cases will go to peer review and that their email reply is the only defense they have in that meeting. And so, now they get emails when they don't meet. I will say this is the first time I've encountered some negative feedback from folks, because getting a QA email is kind of like people still feel, even though it's really effort is for a blame-free culture and quality improvement, it still feels like you're getting your name written on the board. And so, people have had negative reactions saying, well, this person got hit on the head with a shovel. What do you expect me to do? And those kind of conversations. But, I think we've really tried to keep that conversation above the line that, this isn't punitive. We're just bringing it to your attention. This case fell into your negative board. And if you feel okay about the reason you did the CT, so do we. But just explain to us where you are with your decision making, so we can try to find trends among the group and see if there are education holes that we need to fill. So I'm kind of actively trying to manage that conversation and dealing with a little bit of irritation and annoyance from the group, and probably being a little bit pickier about which ones we email out to people, because we don't want to turn people off, especially when we've kind of reached a place that we're pretty happy with. I saw a question about whether we're blinding. Yes, we do blind it. People just see where they are. They get an anonymous identifier. And I'm a big believer in keeping data like that blind, maybe for selfish reasons, because I know once you unblind it, every physician becomes a statistician and an epidemiologist. And all of a sudden, I have to have 70,000 conversations about why their data is different than somebody else's, and where did you get this, and how does it work, and then. So to me, letting people just know where they are, appealing to their own sense of value as a clinician really is, I think 90% is powerful and 100% less painful, and creates a lot less negative environment, I think, as a punitive nature. And we're not in a private group, we're hospital employed, so I don't think people are used to that culture, and it wasn't worth the lift for me.
Seth, it's Sandy. I would also make a comment, because I think it's an important distinction. We're a private group, and I think at times, because I know that there's others on the Beaumont system here who are employed, and I know that you guys are an employed group. I think it's easier for me as a private group to motivate, because there are some rewards that our group sees as a whole for doing well in terms of the the year-end uplift. So that's a little extra carrot that I can dangle that perhaps makes it easier for those departments in the collaborative that are in a private situation versus an employed. I think that's an important distinction.
Yeah, absolutely.